Physiology, something I feel a little bit more comfortable talking about. Okay, so here we're going to be looking at the respiratory system kind of in general. We're going to be looking at ventilation, breathing. We'll talk about gas exchange, also how we regulate breathing, kind of what are the responses that we're going to be kind of sensing there. Hemoglobin and oxygen transport will come up. Carbon dioxide transport, acid-base balance, like you haven't had enough of that already. And then also we'll talk a little bit about high altitude exposures and how the body manages that. So again, the objectives, discuss some of our hematologic physiology. We'll talk about the hematologic components involved in respiration, and then some of that pulmonary physiology and gas exchange. Okay, so the respiratory system. Okay, so this is going to include, basically we're discussing here ventilation, which will be breathing. It's going to be that mechanical process that's going to be moving air into and out of the lungs. We'll talk about how that process actually occurs there. Talk about gas exchange between the lungs, the blood and the lungs, and also between the blood and the tissues, because again, two very different processes will be happening there. And then we'll talk about this oxygen utilization to make ATP, that cellular respiration, how that's also going to involve this process. Because again, the main byproduct of production of ATP is water and CO2, right? So we need to get rid of that CO2, and so the blood's going to be the big thing to do that. So again, we'll consider ventilation and gas exchange within the lungs itself to be this external respiration versus oxygen utilization and gas exchange within the tissues. So once the blood has gone away from the lungs, back into the tissues delivering oxygen, that's internal respiration. A little bit of delineation there. So you notice here in the body tissues, the main goal of blood is to pick up CO2, drop off O2, and then go back out to the lungs to drop off CO2 and pick up more oxygen, go back. Again, hemoglobin is going to be the main carrier molecule here for oxygen. Again, how many molecules of oxygen can hemoglobin bind to? 4, yes, 4 at any given time. Okay, so again, just note here that we'll talk about the acid-base balance and the buffer system again. Notice the red blood cells themselves, the big thing they're going to be doing is not only carrying the hemoglobin that carries the oxygen molecules, but they'll also be responsible for this conversion of carbon dioxide and water over that carbonic acid, which can then break up into hydrogen molecules and bicarb. And that bicarb is going to be useful for helping to buffer the system. Also, it transports that CO2 until it gets to a point in the lungs where it can expel that, and it gets converted back over by carbonic anhydrase. So you'll note that basically when you have these cells dropping off CO2, primarily this gets transported as about 7% as just CO2 just dissolved in the blood itself. A lot of it's going to, some of it can actually be bound via some weak interaction forces with hemoglobin, about 23%, but the majority of it you're going to find it actually gets transported as bicarb. About 70% of that's going to be considered that source of CO2 that gets converted back over in the lungs to be expelled out. We'll talk about the diffusion process here that occurs between the alveoli and the blood, and how we're actually going to be getting this process to occur. We'll talk about pressure differentials and all kinds of good stuff to see how we can get oxygen to the blood cell, get rid of CO2. Okay, so again, we're going to see gas exchange that occurs within the lungs. This is occurring via diffusion. This is all a passive process that occurs here, because again, when we inspire air, about what percentage of that is going to be oxygen? The air I'm breathing right now, about 21% oxygen, about 79-ish going to be of nitrogen, and then other kind of trace gases and things like that. But 21% roughly is going to be the oxygen that we're actually inhaling into our system. And again, things like to go from high concentration to low concentration. And similarly with gases, we're going to find that they like to go from areas of high pressure to low pressure. Like things like to equalize out. And so this is going to be integral for the actual gas exchange process that happens here. So for instance, if I were to breathe in right now, my lungs are going to fill up with O2. What's the relative concentration of CO2 at that point? Low or high? Should be relatively low with the inspired air. And then, because again, if you're breathing in CO2, you're not going to be lasting very long. But then that gas exchange can occur because the blood is going to be carried back to the lungs. It's going to be relatively low in oxygen because it dropped it off all the tissues. So the oxygen can diffuse over. The CO2, which is in relatively high concentration in the blood, is going to diffuse out, and then I can expire that out as CO2. Okay. There's an interesting case study where we actually had some patients who died in a McDonald's because they were actually in the bathroom. Someone found them passed out in the bathroom, and apparently they had asphyxiated. You guys know why that could occur? It's actually the carbon dioxide lines that they used to carbonate the beverages actually had a leak, and the leak was right next to the bathroom, so they're actually inhaling a ton of CO2, and they end up asphyxiating and dying. So be careful the next time you go to McDonald's, as if you didn't have enough to worry about. Anywho, I'm going to collect that fat Burger King check later. Just kidding. So anyway, so again, the O2 concentration being higher in the lungs than it is in the blood, that allows the diffusion to occur there. There's going to be a higher pressure of O2 within the alveoli, as we'll talk about in a second, and that allows for that diffusion passively into the bloodstream. The CO2 concentration in the blood is going to be higher than that in the lungs, so that CO2 is going to diffuse out of the blood pretty easily as well. Again, anything that's getting transported as carbon, as bicarbonate, is going to have to get converted back over into CO2, bicarbonic anhydrase, before it can exit out of the red blood cell or get out the plasma and get into the alveoli to be expelled. Okay. But again, it's all going along its concentration gradient. It's going from the area of high pressure or high concentration to areas of low pressure and low concentration. Okay, so anyway, anatomically, you're going to find we have a conduction zone. Basically, this is getting air down to the respiratory zone. This is going to be areas where no actual gas exchange occurs. So think about things like the trachea, the bronchi, the bronchioles. It's not really down until you get to the respiratory zone or these alveoli where you're actually going to end up getting this gas exchange. So you're going to notice, I'll show you a picture here in a second what kind of the internal aspects of that looks like. But basically, these alveoli where all the kind of the business end of gas exchange is happening here. We're dropping off CO2, picking up O2. So you can just example looking at the conducting zone again, the trachea here. You're going to notice you have the carina and splitting off of the bronchi down to the left and right lung respectively. And again, notice how we have continually increasing number of branches here. This allows us to get a ton of tiny little terminal bronchioles with all these different alveoli, and so we have a huge surface area that we can cause gas exchange to occur. I was reading in the book last night, and they said that the surface area of the alveoli roughly equated to like the square footage of a 25 by 30 room. And if you think about the amount of blood that's in this the lungs at any given point, it's roughly like 100 mLs or 120 mLs of blood. So imagine 120 mLs spread out over that kind of surface area. And you can see there's a lot of room for gas exchange to occur, and it happens pretty easily for the most part, which is a good thing for us, right? We'll look at some disease states where that's going to be affected, and you can run into some problems where they cannot oxygenate very well. So the alveoli are going to be these nice little air sacs where the actual gas exchange is happening. They're going to be wrapped around, or the arteries and the veins are going to be wrapped around the alveoli, so that exchange can happen pretty easily. You can kind of see a cross section here of the alveoli. Notice how we have the capillary here, or the red blood cells are kind of being squeezed through, and the gas exchange doesn't really have very far to go at this point. It's very easy for gas to cross these membranes here. But very large surface area. Basically, each alveoli is only like one cell layer thick, so it's very easy for gas to get across those bilayers. And again, the gases that we're inhaling and expelling are pretty lipid soluble for the most part. So CO2, O2, they're not polar molecules in general, so they're able to cross those membranes fairly easily. You notice that they're going to form these clusters at the end of the respiratory bronchioles, and it's really important that we have a ton of these little kind of popcorn-looking alveoli, because when you we'll see a little bit later on that if you were to have just like kind of one large alveoli here, we'd have a lot less actual gas exchange happening. And that's there's a disease state called emphysema where that actually occurs. You actually end up losing a lot of the membranes between alveoli, and gas exchange ends up suffering because of that. We'll see that in a few minutes. All right, so some other cells that you'll see, you also have these type 2 alveolar cells. They're going to be responsible for sending out like a lot of the mucus that we're going to be seeing, because again, the respiratory tract is kind of coated in mucus at all times. There's some macrophages that are also here. Notice there'll be some white blood cells that will be living around, and once they get that site of inflammation they need to respond to, they can basically start to chemotax over to wherever it needs to go. Red blood cells also obviously going to be coming through here very frequently. And we notice here there's fluid with surfactant. You know what surfactant is? What does surfactant do? Yeah, reduces surface tension of this kind of interface between air and water. So essentially, it allows our alveoli to stay open during all times, right? Do you guys know what would you call it when you have certain areas of the lungs starting to collapse? Atelectasis. Yeah, it's very atelectasis. Part of the lung tissue is starting to collapse, and it does not maintain that kind of nice open patency like we're used to seeing in a picture like this. Okay, just another picture kind of showing cross sections here, what this kind of looks like, so you guys get a feel for that. So very vascular, very well permeated with blood in order to get all that tissue covered and have that gas exchanged. Okay. So again, looking at the alveolar cells, this is where you're going to, I'm sorry, I misspoke. The type 2 alveolar cells are primarily going to be releasing that surfactant. Those are the primary cells where that gets released. Do you guys know of any patients who don't make a ton of surfactant? Yeah, so very, very immature babies are the thing I was thinking about, at least. They actually don't really make a lot of surfactant, so we actually have to, they have problems with their lungs collapsing inappropriately, so we actually have to end up giving them exogenous surfactant. It's kind of interesting. It's one of the few drugs we give through the endotracheal tube. So the infant, is like usually like, if they're like 7 months gestational age or so, we'll give them, intubate them with an endotracheal tube. We'll put surfactant down into the lungs, and you actually have to like kind of rotate them, so that you'll have the surfactant going to different parts of the lungs. So it's kind of like almost like a martini baby, a little bit. You don't really shake them like that, but you kind of move them to different positions so that way that they can get surfactant kind of coating the lungs, and they can have that surface tension reduced. We'll talk more about surfactant a little bit later. But the type 1 alveolar cells is where the majority of the gas change is happening. Type 2 cells, surfactant is being released here. Also helps to prevent fluid buildup by reabsorbing sodium and water, right? Because when you have too much fluid in the lungs, what do you call that? Pulmonary edema, so we don't want that to happen. So the alveolar type 2 cells are really important for doing that. Okay, so again, the paths of the airway, essentially what it's going to do is air travels down the nasal cavity if it's inhaled through the nose, or through the oral cavity, unless you're like a mouth breather, and that's the primary way you have that happen. It's the pharynx, goes down the larynx, where it can go through the glottis and the vocal cords, and finally through the trachea. At that point, it's going to be split up between the right and left main bronchi. Notice here we have the carina, which is right there, and then you're going to have secondary, tertiary bronchi. You're going to have these terminal bronchioles and the alveolar sacs at the very bottom. Okay, so keep in mind there's also like smooth muscles going to be surrounding a lot of these bronchioles. When I mentioned asthma causing constriction of those, that's where that smooth muscle is causing impeding airflow when you have that occur. So, and in order to keep the trachea open, we have these cartilaginous rings that can help with that as well. So it's kind of interspersed with our cartilaginous rings, and then also some of that smooth muscle to try to keep things nice and patent. Okay, have you guys covered this in anatomy yet? Okay, you probably will shortly. Anyway, so looking at laryngoscopic anatomy, so if you were trying to intubate a patient, you guys ever seen someone intubated before? Or you've seen probably on TV or something. So usually there is a blade that they are putting down the patient, down in the throat. Usually the blades try to keep the tongue out of the way and try to open things up a little bit so they can actually intubate the patient. So they'll have an ET tube that will actually go through this area here. Here's the blade. They're trying to keep the tongue out of the way, right? Basically, you can see the vocal cords, which are really important for producing sound. You have the epiglottis, which is normally used to, what does the epiglottis do? Yeah, actually, yeah, we'll close up over the trachea to make sure that when we swallow, we don't have like things going down the airway, which is not good. The glottis as well. And basically, the point is you want to make sure you see the vocal cords, and then you can put the endotracheal tube right down in between those, and that way you have a patent airway now. That way you don't have to worry about the patient breathing on their own. We can now breathe for them. Notice how the esophagus is going to be squeezed down here. Sometimes there's a piece of cartilage called the cricoid cartilage, and when you're intubating, they can actually request that you put pressure on that so it actually will close down the esophagus to make sure you actually get the ET tube down in the right spot. Because sometimes you can actually accidentally intubate into the esophagus, and then you're trying to aerate them, and they're just going to get a blown up stomach, and that's no good, right? So we want to make sure they actually get through the vocal cords, get the tube down, and usually they're going to put the tube some number of centimeters down here. You don't want to. Sometimes you can go down too far and actually have a main stem into one of these airways. So you end up pulling it. You should kind of rest around this kind of area right here in general. So that's why you'll get X-rays after intubation to see kind of where that placement is. Okay. And so looking at, you can see that cricoid cartilage I mentioned there. Notice how it's underneath the thyroid cartilage, and it's going to lead up into the Adam's apple there. This is the larynx, the trachea, and then you have your different bronchi. This is kind of interesting. You guys ever heard of like the bodies exhibit? And they took these like cadavers, and they were able to use all kinds of different techniques to look at different anatomical things. And so essentially one of the things they did was they took one of these cadavers and placed this kind of wax substance all throughout the lungs. And you just notice just a huge amount of surface area that would be included in these patients. So when they're breathing in, like all those airways should be getting filled up for the most part, and all of them are being perfused to cause that gas exchange to happen there. If you ever get a chance to go see that, I would definitely recommend it. Not for the faint of heart if you're icked out by that stuff, but you guys are in PA school, so you shouldn't be icked out by body stuff, right? That's why I went to pharmacy school, because it did ick me out. So, yes, sir. Yeah, so so the question was, what's the difference between pulmonary edema and acute respiratory stress? Pulmonary edema can eventually lead into acute respiratory distress syndrome, where essentially, for whatever reason, like you're not able to have good gas exchange actually occurring there. Some of it can be related to collapsed lung, like if you have the atelectasis that occurs, or if you're like lacking surfactant, that can lead to respiratory distress. It's kind of more of a kind of a broad term, but pulmonary edema can be one of those things that can precipitate going into ARDS. Yep, good question. So some of the functions of the conducting zone of the respiratory tract is we're going to have transport the air down into the lungs. It's really important that we're going to warm, humidify, and filter the air that's coming through there. So that can be very useful, especially like in the nose. You can have the air goes through these turbinates, where it's able to help it to get warmed very well, humidifies the air, so that way it's going to have a decent amount of water in there. One of the problems you run into, especially with like ventilated patients, when you're breathing for them for a long period of time, is if you're not humidifying that air, it can end up drying out all the respiratory tract. That mucus is going to dry out, risk for infection, all of that. So you want to keep things nice and moist for the most part. Also, you're going to have the cilia. It's going to move it away from the lungs. Everything's going to be kind of pulsating towards the pharynx, so that way you can just swallow it and get rid of those particles there. And we mentioned the voice production, and this is going to happen in the larynx as the air actually passes over the vocal cords. And so based on how the muscles are contracting those vocal cords, you can have different timbres and all of that to produce sound. So you guys are probably wishing that I would rest these muscles here, but I'm going to keep going anyway. So again, right, so we have the tongue here, you're going to have the epiglottis, this line there, usually it's kind of a protective mechanism, and then we're going to have the true vocal cords, which are going to lie right here, which again, they can kind of, depending on how the muscle's kind of pulling them or loosening them, they kind of change your edges, which allow you to get kind of different sounds from those vocal cords. You also have the false vocal cords coming out on the outside here, that will also help with phonation or voice production. And you can just kind of picture what that would look like with the vocal cords closed there. So we'll get much more of that probably in anatomy. But you notice how these muscles, I had to look up how to actually say this word, so I didn't want to say it incorrectly. But it's the thyroarytenoid muscle, so you can have that kind of pulling the vocal cords via this cartilage here. Then you have the lateral muscles, posterior muscles. All these can change the conformation, basically, of those vocal cords to allow for kind of different sounds to be made there. So you can notice here if you're having kind of full or gentle abduction of the muscles, you can change, you're having kind of a whisper, stage whisper, or of course, as you're having actual phonation, those cords should be together, kind of vibrating together to allow for that sound to occur, right, as air passes through. All right, then looking at the thoracic cavity, you're going to see we have the mediastinum is going to contain basically the heart, the trachea, the esophagus, and the thymus, so basically this whole area kind of here. Basically, it's going to be the area between the right and the left lung. And then the lungs are going to fill up the rest of the thoracic cavity there. So you're going to have the parietal pleura, actually lines the thoracic wall, kind of along the, right here, the pleural cavity. The visceral pleura is going to actually cover the lungs itself. And then there's going to be a potential space between the two, the kind of intrapleural space and this cavity here. So, and typically the very little space between these two, they're kind of, with surfactant, are able to kind of stick together due to a kind of a slight suction that occurs, and that's what allows our lungs to stay inflated at all times. Okay. And then the diaphragm is also going to be a very important muscle. It's a dome-shaped muscle that allows for kind of easy respiration in most cases. So when you have an inspiration, that muscle is going to be contracting, and that's going to pull down and allow for air to come into the lungs, right, by causing kind of a negative pressure vacuum there to some degree. Okay, so looking at kind of a cross section of this, you can see the mediastinum here. Notice, I guess this would be the right lung and the left lung here. I think. I'm sorry, this is the left lung, this is the right lung over here. Basically, you can see the mediastinum, see how the lungs, notice there's a very small space here, but it's important that we make sure that the lungs stay kind of attached in that pleural cavity, because otherwise if they don't, that's when you have that collapsing of it occur and lead to atelectasis, lead to poor oxygenation. We'll talk about perfusion, ventilation mismatches and things like that later on, but it's important that the lungs stay inflated at all times. In case you were, again, I'm not going to be the expert at reading x-rays at all. I can tell you there's a heart there, and there's probably two lungs. But again, just some examples of x-rays. You can notice kind of the difference between these two. What do you think the difference is between these two x-rays? Well, yeah. So one's looks like a female there. Also notice like one's inspired, one's kind of expired, right? So this person is breathed in. So you normally like to have them breathe in, so we can get a good full view of the lungs. Versus this person probably just kind of in the middle of an expiration, probably. So it looks like a lot smaller volumes there. But again, you guys will get this in other classes in much more detail. Again, it's one of those things where the pharmacist can look at an X-ray and be like, "That looks bad," then you know it's real bad. So usually there's like some kind of empyema, or if there's some other sort of big issue, I can notice that stuff. That's about it. Okay, so then moving into ventilation, so looking at intrapulmonary and intrapleural pressures that occur there. So we like to have several different types of pressures we'll discuss during this lecture. Basically, there's atmospheric pressure. It's going to be the pressure of the air is going to be outside of the body. We're going to just assume we're at kind of sea level and just talk about it from that standpoint. Basically, if you're thinking at sea level, most air pressure should be around like 760 millimeters of mercury, I believe. And so we said that the breakdown of that is a large percent of that's nitrogen, and a large, about 21% or so is oxygen. So roughly the atmospheric oxygen pressure is around 140-ish millimeters of mercury. So keep that number in mind. It'll be important for we're talking about actual transmission of that air and how that pressure is going to lead to diffusion occurring. But basically, we're going to have the intrapulmonary or the intraalveolar pressure, so the pressure in the lungs, which typically is going to be lower. Then you'll see kind of a slight suction in most cases. And then you have the intrapleural pressure. So again, this is going to be basically the pressure between the intrapleural space, so between the parietal and the visceral pleura. And that's we're going to contain that thin layer of lubricant, usually surfactant, that kind of helps to serve to keep those together, right? So again, we have collapsed lung or something like that, or if you were to have, say, like a pulmonary contusion, we have like blood kind of filling in that space, that can affect that. If you end up having, I'm trying to think of any other conditions, I can't think of the name off the top of my head, but yeah, so basically you want to have that space being filled with the lungs at all times when possible. Okay. So you can kind of see the pressure differentiations when you're kind of inspiring. Basically, you can look at the intrathoracic pressure on the mediastinum, so basically the pressure on the cardiovascular system. We mentioned how this can have an effect on things like the valves closing. We mentioned when you inspire air, what happens to your S2 sound? Remember, it splits, right? Because you're going to end up hearing the aortic valve close before you're going to hear the pulmonic valve close, right? Because you're going to have lower pressure within the lungs, and that leads to it takes longer for that to end up closing there. So again, go back and you can review that. But essentially, you can find how that air pressure can have an effect on the heart and have an effect on filling as well. You kind of see how you're going to have this kind of pulsatile nature as you have changes in inspiration and expiration. Okay. So again, inspiration are going to be inhalation of these. Basically, you're lowering the intrapulmonary pressure. It's going to be lower than the atmospheric pressure. So by lowering that, the air is going to flow from area of high pressure to low pressure. So that's why it's drawing air into the lungs. And then during expiration or exhalation, intrapulmonary pressure is going to be greater than atmospheric pressure. What do you think are the muscles that cause expiration to occur? Yeah, so a lot of times you're going to find that at rest, you're going to have just passive relaxation of the diaphragm will actually cause expiration of a lot of that gas. And sometimes for a forceful expiration, you're actually using abdominal muscles as well in order to force that gas out. But in general, and just kind of quiet breathing, just relaxing the diaphragm allows for kind of just natural passive expiration. Because again, the pressure's higher now, so it can push that air out of the lungs. So you can notice on the picture here, you have someone who's at rest, say the atmospheric pressure or the intrapulmonary pressure and intrapleural pressure here, roughly the same for the most part. Atmospheric pressure around 760. When you are causing inspiration, notice he's going to drop a few degrees of mercury. You don't need much of a suction there, but a little bit. And then for expiration, the pressure is going to be a little bit higher. It's going to cause air to be expelled. So pretty straightforward. Okay, so also what we call Boyle's law. Basically, is going to be stating that the pressure of a gas is going to be inversely proportional to its volume. So what do you think that means? Yeah, so as volume is increasing, you're going to see a decrease in the pressure, right? So basically, if we have an increase in lung volume during inspiration, that decreases the intrapulmonary pressure, and the air is going to flow in, right? So again, just going from kind of areas of high concentration to low concentration, high pressure to low pressure. For decreasing in lung volume during expiration, that increases. So again, we're kind of compressing the lungs. We're allowing that space to close. That's going to force the pressure to go up and cause the air to expel out of the lungs. So it's going to be Boyle's law for that one. There's also a high degree of elasticity in the chest cavity, so you're going to find that the lungs like to return to initial size after being stretched by that recoil, right? So after being kind of stretched out, they're going to go back to their normal size. Notice they don't collapse up completely because we have that nice that intrapleural cavity there. We're going to have that nice surfactant that kind of holds everything open for the most part. So again, because the lungs are going to be attached to that thoracic wall, they're always under elastic tension. And again, during inspiration, that tension increases as it kind of pulls it open, and then tension is going to be reduced by that elastic recoil during expiration. Okay. So in here we see inhalation. Notice how the diaphragm is going to be contracting, so it's going to pull down. If you were to have, say, more muscles involved in breathing, usually you're going to see your intercostals get involved, so the muscles between the rib. Basically, it's going to help pull the lung outwards. That helps to stretch everything out. Again, that's going to reduce the pressure. It's going to allow air to flow in from the atmosphere, versus if we're contracting, so your chest is going to recoil back down, diaphragm relaxes. Sometimes you have abdominal muscles also closing this down some, and it's going to cause pressure to increase, air expires. You also have this law of Laplace. I don't know if that's the right pronunciation. I'm not French by any means. But basically, pressure is going to be inversely proportional to the radius of the alveoli. And so this is going to be really important that lower radius means lower pressure. I'm sorry, large radius is going to mean lower pressure, and so we like we want to keep high pressure in a lot of these cases. So small alveoli end up being greater, would be at a greater risk for collapse without that surfactant. So essentially, what you find is that when you have these small alveoli, they're more likely to collapse because we have that surfactant kind of reducing that surface tension and holding them open. They don't end up having that occur. But this is also important because if you were to have, say, a very large alveoli, notice how the pressure is going to be decreased. And you can look at this picture here. You can kind of see how, you know, for by decreasing that radius there, you get basically 2 times the pressure. What that means is if you have a lot of small alveoli, that's really good for helping with gas exchange. But when you start to have these break down, the walls between alveoli, and you end up with the kind of these more large alveoli, gas exchange doesn't happen as well. And that's why I mentioned that emphysema occurring there. So again, surfactants keeping the alveoli open. We like to keep a little bit smaller radius here, so that way we can go ahead and keep higher pressures. I'm not going to force you to do the math on here, but just realize that the larger the radius we have here, it's going to end up having lower pressure than it would be over on this side here with a smaller radius. Okay. So again, there also, when you have that expiration occurring and that lung volume is decreasing, that higher pressure here is also going to help to force that out of the lungs. You also have issues here as well if we had different sizes of alveoli. Notice how some of this air is kind of being trapped here in these larger alveoli. That can be a problem as well. Some of our patients with like kind of chronic lung disease, they can end up having air trapping, and so you can have these. We'll talk about pink puffers and blue bloaters, but essentially you can have patients who are trapping a large amount of air, so these big barrel chests, but they can't really oxygenate very well, and some of it is related back to these differentials in pressure. Okay, so we mentioned surfactant, and now we're talking about respiratory distress syndrome. So again, we mentioned surfactant being secreted by those type 2 alveolar cells. They can consist of both a hydrophobic protein and also a phospholipid. I mentioned basically this helps us to reduce surface tension between water molecules and also reduce the number of hydrogen bonds between those water molecules, because you know, what would like to happen is alveoli would just kind of collapse in on themselves and you couldn't really ever pull them back open. But the alveoli having those that surfactant helps to reduce surface tension, keeps it nice and open, and prevents that collapse to occur. It also means you're also going to have a residual volume of air that remains in the lung at all times. So can you ever expire all the air in your lungs? You wouldn't want to do that because you wouldn't be able to get your lungs back open if you collapse everything. So we like to keep some residual volume, and we'll look at that when we look at our pulmonary function test in a little bit. So mechanisms of breathing. You guys are all great experts at it, right? This is also going to be called pulmonary ventilation. We mentioned inspiration, breathing in, expiration, breathing out. Basically, it's going to be achieved by changing that thoracic cavity and lung volume. So you can talk about the muscles that are going to be involved with that. We'll talk about that more in detail. Basically, the thorax has to be rigid enough to provide protection for the lungs, and also be flexible enough to cause changes in breathing, right? So has allowed to make sure we don't have issues like damage occurring here, but again, that's why the ribs are nice and spaced out, so they allow for kind of some flexibility there. We can have inspiration occur. And another picture kind of showing the differences between lung volumes between someone who is expired versus someone who is inspired. There you notice how this is kind of the original markings here on the left. Notice how much more volume is going to be there for oxygen to come in. So basically what you end up seeing is when you have breathing, so during expiration, you can have just the diaphragm just relaxing, which will allow for the lung volume to decrease. So it's going to, as it pushes up, it's kind of dome-shaped as kind of natural conformation. You also, when you have the abdominals contracted, that can also force out additional air. So when you have kind of a forced expiratory phase, you're going to have those abdominal muscles contracting. On the other hand, when you have inspiration, they're going to have the diaphragm contracting to pull down to increase that lung volume. You're also going to end up having elevating the rib cage, so this helps to increase the vertical diameter, increases the apical diameter. The anterior posterior diameter. The external intercostals end up being contracted, so they're going to help to pull it up, and then the internal intercostals end up being relaxed in those cases. So all these things help to provide for a larger cavity for the air to flow into. And because everything's elastic, it'll kind of pull that together when you expire again. Last hour, we can make it. All right. So just in case I misspoke, someone else pointed out, this is a problem with speaking for 4 hours straight. You're going to misspeak quite a bit. But so surfactant, specifically for the alveoli to prevent closure there, there's serous fluid that helps keep in the intrapleural space that helps keep the lungs straight. It's not really surfactant there. So if I misspoke, that's serous fluid that just keeps that all together, right? Kind of that kind of slippery glue that holds it all together, so that way you can still have movement, but it holds the lungs intact. Everyone with me? Okay. Keeping going. Looking at inspiration and expiration, the muscles involved here. You're going to have the diaphragm is going to be the most important when you're just kind of breathing quietly at rest. Like this is primarily the only muscle you're going to be using. We have contraction that flattens it and is going to pull the lung volume. It's going to increase that, and then just relaxing causes expiration. Right? You're going to be causing that elastic recoil. The muscle is going to move back up, closes that volume down, that increases the pressure, forces air out of the respiratory tract. So the external intercostals are going to raise the rib cage during inspiration. So if you need like some extra space, you can use the external intercostals for that. There's also going to be some accessory muscles as well that can be useful. So things like scalenes, pectoralis minor, sternocleidomastoid, all those can be useful working with the external intercostals for inspiration. So if you need to take a that's going to be all those accessory muscles being involved there. And that can be useful when you're evaluating a patient. Yes, okay, are they using accessory muscles when they're breathing? Because that would indicate what? They're working pretty hard, right? So if someone's just sitting there breathing, like, not really a big deal, right? But if you're looking at someone like that's going to be a sign that, hey, they're working pretty hard. This may be a sign I need to do something about this before they crump, right? Because again, people can only keep up that sort of breathing for so long. Afterwards, they're going to tire out, and then they stop breathing. That's no good. So we wanted to assess that beforehand. Okay, so again, normal quiet expiration is just going to occur with relaxation of the inspiratory muscles. It's a very passive process for the most part. You'll also notice the internal intercostal muscles can be useful for lowering the rib cage during that forced expiration. So you need to really kind of force out all that air. The internal intercostal muscles can help with that as well. So basically kind of pulling that rib cage back down. Again, the abdominal muscles are also going to be useful for forcing the expiration out as well. So those will tighten up, force out the air. Okay, so again, just another picture kind of showing the same thing here. Just notice how your abdominal muscles, the internal intercostals are going to be useful for expelling that air. External intercostals, your sternocleidomastoid, your diaphragm, all of that going to be useful for inspiration. Okay, so again, with inspiration, you're going to volume of the lungs is going to increase. The diaphragm contracts, and those parasternal and external intercostal muscles can raise the ribs. That's going to allow the thoracic and lung volumes to increase. That pulmonary pressure is then going to decrease because then you're creating a larger space. The air is going to flow in. Okay, we already mentioned that. Expiration is the exact opposite is going to happen. Closing up that lung volume is going to force the air to go out at that point. So the intrapulmonary pressure is going to increase higher than the environmental pressure. That's what forces the air to go out. Okay. So just another showing the same thing here. Just notice that the pressure differential is really not that big. Only about 3 millimeters of mercury is enough to cause normal quiet breathing to change. But when you're trying to have more forced inspiration or expiration, there's pressure differentials are going to be much higher. So like anywhere between 20 or 30 millimeters of mercury or more. Yeah. Okay. So you can just looking at the difference in the pressure, show this picture previously, but during inspiration you only have maybe like a 3 millimeter drop here. It allows the air to flow in pretty easily, and then we have during expiration we're going to decrease that lung space, increase the pressure maybe about 3 millimeters of mercury, and force the air out. Okay, so we have pulmonary function tests. This is going to be very useful for especially monitoring patients over time. If they have any kind of chronic lung disease, to assess how, especially changes, right? So you can assess major problems initially, but you want to be looking for changes over time as well. And so we can use spirometry, where basically the subject is going to breathe into and out of a device that records that volume and also the frequency of the air movement on spirograms. So you can kind of see the spirogram here is going to be detecting several different values, which I'll go into in a second. This also helps with measuring lung volumes and measuring capacities for things like inspiration or expiration, and can help you to diagnose restrictive or any kind of disruptive lung diseases. So if you have a patient who has like chronic obstructive pulmonary disease, this is going to be able to detect those changes over time as they get worse and worse if they don't stop smoking or whatever happens to be. So looking at their PFTs, and we'll go over these in more detail, but basically you're seeing lung volume here on the y-axis, which is going to be measured in basically liters or thousands of mLs. Time is going to be on the x-axis here. So what you can see is a normal inspiration, expiration happening here. This is just during quiet breathing. Remember, this is going to be the diaphragm pulling the contracting and pulling that lung volume open, and then that passive expiration process where you just relax the diaphragm. And then you can have a forceful inspiration. This is going to be much higher. And then back down, and then we'll go back to normal breathing, and then you have a forceful expiration, and then you can actually do both, where you have a forceful inspiration, and then you breathe everything out. And that's going to be able to tell us several different values, which we'll talk about more in detail in just a moment. So, look at the tidal volume. Tidal volume is going to be the amount of air that gets expired and inspired just in normal quiet breathing. So most of you guys are going to have a set kind of tidal volume that you're experiencing right now. In a lot of cases, for I think like a 70-kilo male, it's like 500 mLs is roughly tidal volume for most patients. And that can change depending on kind of what the environment is. It can depend on altitude if you have not had time to adapt to that yet. So that can change, but typically it's just kind of quiet breathing volumes. You have inspiratory reserve volume. This is going to be measured as the amount of air that can be forced in after tidal volume. So basically the delta between your upper tidal volume and the kind of maximum that you can inspire, this is the inspiratory reserve volume. Okay, this is going to be just the difference between these two values here. And then inspiratory capacity is that total amount of gas that can be inspired after normal expiration. So this is going to be the tidal volume plus that inspiratory reserve volume. Okay, so you put these two together, you get inspiratory capacity. Or if you just know two of the values, you can figure out the third one pretty easy. Okay. You can look at expiratory reserve volume. This is going to be the amount of air that can be forced out after tidal volume. So you can see expiratory reserve there. Residual volume is going to be the amount of air that's going to be left in the lungs after maximum expiration. Is this super easy to measure, do you think? Not really. There's some specialized tests that they can do to measure this, but you can't ever get rid of that residual volume, otherwise your lungs would collapse. It wouldn't be good. So it's more difficult to measure, but it can be done with some certain tests there. But your functional residual capacity is going to equal to the amount of gas left in the lungs after normal expiration, which again is going to be that residual volume plus that expiratory reserve volume there. So again, there's a functional reserve capacity. You can notice that right here. Pretty straightforward. And then your vital capacity, this is going to be that amount of air that can be forcibly exhaled after a maximum inhalation. So basically, you notice your vital capacity is going to be basically you inhale all the way and then expire as much as you can. And so this is going to be the vital capacity. You can see that line right here. And so the total lung capacity should be equal to the amount of all gas in the lungs. It should be equal to the inspiration reserve volume plus tidal volume plus that functional reserve volume there, or functional reserve capacity. Can be equal to the vital capacity plus the residual volume. Any of these things can be added together to get your total lung capacity there. So, all right. You can also look at your total minute volume, so you can measure basically how many breaths they're taking plus times their tidal volume. Roughly if you are just normally breathing, maybe 12 times a minute could be average for some people. And so the tidal volume times that breaths per minute ends up giving your total minute volume. Okay. I see this most commonly in the ICU setting after we intubate a patient. It's important to make sure that you're setting the tidal volume for the patient. You're setting things like their minute respiration and all those things. And so we're setting these values because the patient's not breathing on their own. So that's probably where I most often run into doing these kind of tests or setting these kind of values for a patient. Actually, one time I was on rotations in school, and we got to hang out with a respiratory therapist for the day. And so he gave us all these mouthpieces and put us on a ventilator essentially. So I just had mouthpiece, and having something breathe for you is a very odd kind of sensation. But I was only getting like 500 mLs for a tidal volume, and I was just like, I'm gonna die. This is not enough air for me. Like I need more air, and he wouldn't give it to me. It's terrible. So think about that. Think about, if your patients are ventilated and they're, still having some degree of consciousness, they could be experiencing quite a bit of these kind of uncomfort. So you want to make sure your ventilator settings are set appropriately so you can avoid any of these issues that pop up. You can see a spirogram, how this would look. Again, same volumes, essentially all the same pictures here. You can just be aware if, like, on a test purpose, if I were to say, hey, what is the maximum amount of air you could breathe in after a normal inspiration, and you would say, hey, that's going to be the inspiratory reserve volume. Being able to identify those based on definition would be good to know. Okay. Some other ventilation terminology. So again, air spaces are going to be anywhere this the actual air exchange can happen here. So the alveolar ducts, alveolar sacs, and alveoli. The airways is obviously going to be the structure where they're actually transmitting the air in and out of the respiratory tract. Alveolar ventilation we're going to refer to as being that removal and the replacement of gas in the alveoli. Basically, it's going to be that tidal volume minus the volume of dead space times the breathing rate. And so, do you guys know what dead space is? Besides a pretty good video game. So essentially, it's going to be all of the space in the respiratory tract, usually in that conducting area where no gas exchange is actually occurring there. So like, you're not exchanging gas in the trachea, but that's still full of air at all times. So that's considered dead space. So that's going to be considered anatomical dead space, where you're going to find that it doesn't matter what condition, if it's a normal healthy person, they're never going to have gas exchange in the trachea, for example. You can have physiologic dead space, where you can have issues to where maybe a certain area of the lung is collapsed, and now that's not being aerated well. So there's a little bit of difference there, but basically that's air that's in the system is not being utilized appropriately. Okay. So you can have apnea. Apnea is basically going to be that cessation of breathing. What are some reasons you can have apnea? Yeah, so you can have like obstruction, right? So if you're sleeping and you have a very large neck or things like that, you can have closure there. You see that in a lot of like obese patients. You can have drugs that can do this. So opioid epidemic, right? Everyone's living through that right now. That can certainly be a cause for apnea in some patients. Dyspnea is just going to be that kind of unpleasant or subjective feeling of kind of labored breathing. So if you're not really able to ever catch your breath, it's a very kind of a very uncomfortable feeling for patients. So we just term that as dyspnea. Eupnea, not a term I ever hear clinically very often, but that's just going to be normal, comfortable breathing at rest. So you guys are mostly eupnic right now. I don't see anyone kind of hyperventilating. And the hyperventilation is just going to be that alveolar ventilation that's in excess of the relation to the metabolic rate. So if I'm breathing more so than I really need to, what that's going to do is you're going to get rid of excess carbon dioxide. And so when you get rid of excess carbon dioxide, what do you think that does to the pH of the blood? Causes it to actually go up. So remember, CO2 is going to be intrinsic to the pH. So the more CO2 I have in the system, the more acidotic I'm going to become, lower the pH is going to get. So if I blow off a lot of CO2, if I'm hyperventilating, like I'm really nervous talking to you guys, I'm like, and I blow off a lot of CO2, I can get very alkalotic, I can get lightheaded, and can pass out, right? Yesterday, I think it might have been yesterday, when I mentioned breathing into a bag, that's what they actually do to prevent the alkalemia, because when you breathe into a bag, that's actually circulating CO2 back into the system, try to keep you somewhat, your pH somewhat normal, right? You have hypoventilation. This is where basically you're having alveolar ventilation that is low in relation to your metabolic rate, so you're getting a buildup of CO2, which would cause you to become acidotic over time. We'll talk about the differences between metabolic and respiratory acidosis, but all of it goes kind of back to your CO2 levels. Mentioned that physiologic dead space already. There's pneumothorax, which is the term I could not think of before, but basically if you end up getting an air space in between the intrapleural space, you can end up having potential lung collapse. So basically that pressure of that air in the intrapleural space can push the lung closed, essentially, which can be, one, very painful, and also prevent oxygenation occurring. Any question? Functionally, pneumothorax is specifically just having that air in the space, which can cause some lung collapse. Atelectasis is more just usually due to like a disease process where you're seeing like either like fluid building up in the lung or something's going on. So you usually said more atelectasis like in like pneumonias and things like that. I'm not sure though. Maybe if you talk to someone else, they would have a different opinion on that. Atelectasis is probably a general term. It is a general term. Yeah, so right, so pneumothorax causes atelectasis, but not all atelectasis is due to pneumothorax. How about that? That work? Yeah. Yes, I think that works. Right, so again, pneumothorax, and do you guys know how they go and deal with that? Yeah, actually they puncture in the chest cavity, whatever side it is, and they'll actually release the air. So it's really cool if you ever see it, because they'll put the needle in, all of a sudden you hear, and then the patient's just like, oh, I feel so much better now because my lung is able to expand appropriately. So it's pretty cool if you ever get to see that like in a trauma setting or something like that. And then torr is basically just going to be that unit of pressure equal to nearly equal to the millimeter of mercury. So if you see torr, it's just another reference to pressure. Basically, it's very similar to mm's of mercury there. So again, looking at forced expiratory volume is another lung test you can do. This is going to be FEV1, which is going to be the forced expiratory volume over 1 second. So basically, this is the percent of vital capacity, or the volume of air that can be forcibly exhaled in 1 second after full inspiration. So you may have the patient kind of inspiring normally, have them take a full inspiration, and then have them force out as much as they can, and you measure what comes out over that 1 second. Basically, you can monitor that. That's one of the things they'll look at, like in asthmatic patients and patients with chronic lung disease over time to see if that's getting worse. That can be indicate just kind of worsening disease for those patients. But again, the max they can expire over that 1 second to determine kind of over time changes that are happening there. Again, I'm not going to get super into the math. I may cover that in other classes, but essentially we can do some math here to look at the actual percentage. We're looking at, if you know the total vital capacity, you can compare that with the FEV1 in order to get that percentage there. So you should be able to expire a lot of the air out over that 1 second. But some patients who have maybe some obstructive issues, they may not be able to force all that air out at once, and so it's a smaller percentage at that point, right? So for instance, someone who had kind of normal lung function, they'd be able to force all that air out very quickly, versus someone who had maybe an impeded airway or some sort of obstruction, you may see they not be able to force as much air as quickly. Okay. So for instance, if I had like an asthma attack and I had my bronchial smooth muscle constricting, that would close up those airways to some degree, and that would cause my FEV1 to go down, essentially. Just another picture showing kind of a normal airway versus an obstructed airway. Notice here how the percentage for a healthy patient is going to be a lot bigger of that, the percentage of FEV1 over the full vital capacity versus someone with like an obstructed airway. Okay, so the next going on to gas exchange within the lungs. So you have Dalton's law. Basically, Dalton says that the total pressure of gases in a mixture is equal to the sum of the pressures in each of the gas in it. This is kind of what I referred to previously as saying that kind of atmospheric pressure is around 760 millimeters of mercury or so. We mentioned like 79-ish% of that is going to be made up of nitrogen, 21% that's going to be oxygen. And you'll see how this is going to differ as you get down into different parts of the lung. As you humidify air, part of it's going to be due to water now. You'll see how those pressures are going to change over time. Basically, if I put gas A here, which has a pressure of 300 millimeters of mercury, plus gas B, 400 millimeters of mercury, the total should equal out to be 700. Okay, so all going to be summative in those cases. The partial pressure is just going to be that pressure of an individual gas that gets measured by multiplying that percent of that gas by the total pressure. So for instance, if I had that, talking about the atmospheric pressure being 760 millimeters of mercury, times that by 0.21, I'm getting the partial pressure of oxygen in the atmospheric air. So here you'd see that it makes up roughly 160 millimeters of mercury. Okay, that would be like at sea level. Obviously, that would be changed by altitude in several cases. Okay, so you can see how this can change with altitude and location. So for instance, if you're at sea level, kind of like we're at here, atmospheric pressure is going to be around 760 versus if you start to travel further and further up, maybe if you're somewhere around Colorado or somewhere, notice how it's gone down fairly significantly. And notice how the partial pressure of oxygen is going to be going down as well, right? And then as the total pressure is decreasing, the partial pressure of oxygen will also be decreasing along with that. Okay. Also notice that the PO2 in the alveoli is also going to be taking a hit as well. Right, so as we inspire air into the lungs, there's going to be some gas exchange that happens that dilutes out some of that oxygen. So partial pressure is going to go down normally anyway, and we want to make sure there's a differential here between the alveoli and the arterial blood, because if there wasn't a difference here, what would happen? Basically, there'd be no gas exchange occurring, right? So we need to make sure we have a higher pressure in the alveoli of O2 versus that in the arterial blood. That makes sure that we are able to donate that blood, and specifically when you have venous blood coming back into the lungs, you want to have that, make sure the O2 concentration of the partial pressure there is roughly around 40. So by having that differential between say 105 to 40, that oxygen can diffuse over, and then now we have something pretty close to the what we have in the alveoli, and that can be circulated around to the tissue. Okay. So you got to have that pressure differential, otherwise they're not going to have that flow of oxygen into the blood. But this is also why that as you get higher and higher up, you're going to notice that, like if you were in a plane that was not pressurized, you'd be breathing pretty hard because you're not able to deliver as much oxygen. Not as much of that will be dissolved in the blood. Okay, all that is related back to the oxygen you're actually delivering in the inspired air. Okay. So again, looking at the significance of blood PO2 and PCO2, that's just the partial pressure of O2 and partial pressure of carbon dioxide measurements. You'll see that it only really measures oxygen dissolved in the blood plasma. It's not going to measure the actual oxygen bound to hemoglobin in the red blood cells. There are other tests that you can do for that. You guys are familiar with the ABG? It's arterial blood gas. That can actually tell you what percentage of the hemoglobin is actually bound versus deoxyhemoglobin. It's also like when you put a pulse oximeter on your hand, like that's actually detecting the difference between oxygenated hemoglobin and deoxygenated hemoglobin. But when we're specifically looking at the ABG and looking at the PO2 or the PCO2, we're really only talking about the actual amount of oxygen that's dissolved in the plasma. Okay. So anyway, when the lungs are going to be functioning properly, the PO2, the systemic arterial blood, is only about 5 millimeters of mercury less than the PO2 in alveolar air. I mentioned because once they travel into the lungs, and say for instance we get here the lung up here, the muscle down here, we're delivering oxygen. That PO2 coming in from the veins is going to be desaturated to some degree because it was delivering that oxygen to the tissue. So maybe only have a PO2 around 40 millimeters of mercury. Here, because of that tissue differential, we're going to have a PO2 of maybe 105 to 40. That O2 is going to travel into those red blood cells. Now it picks up and has roughly an O2 of PO2 of around 100. Okay, so it's not going to be exactly the same, but it's going to be pretty close for the most part. Then that can be circulated around. I'm going to drop off that PO2 into the muscles, and then it's going to get dropped down to around 40 again, come back and get recycled all over again. Okay, so all right, then a normal PO2 of around 100, you're going to notice that hemoglobin is going to be almost completely filled up with O2. We're going to look at the oxygen hemoglobin desaturation curve and see that, but roughly when you're at around 100 millimeter, at a PO2 of 100 millimeters of mercury of oxygen, all that hemoglobin will be bound up. So all 4 molecules will have oxygen attached to it. You guys know how many molecules of hemoglobin would be filled up when you get to this point under normal circumstances? About 3 of them. So you would lose basically 1 oxygen off one of those hemoglobin chains. You still have about 3 oxygens attached to hemoglobin. So again, when you circulate blood around the body, you're not losing all the oxygen. There's still a decent amount of oxygen left, which is why you can hold your breath for a while and not completely just die, right? That wouldn't be good. So you still have a decent amount of oxygen stores on that hemoglobin left over for some period of time. Okay, again, kind of just going whatever it went already. Again, notice also the concentrations of PCO2, right? So we mentioned that carbon dioxide should not be in very high concentrations in the atmosphere. So the inspired air that we have should be almost no carbon dioxide. The alveoli concentration is going to be higher just due to that differential between what's in the bloodstream and also what's in the alveoli. So when you have PCO2 coming back into the lungs, notice it has a PCO2 of around 46. That's going to cause the differentiation, differential to go into the alveoli. And so then when you have PCO2 coming back out, it's about 40 or so, right? So you're not getting rid of all CO2. And why do you not want to get rid of all CO2? It becomes super alkalic. It wouldn't be very compatible with life, right? So you need that CO2 to help maintain that acid-base status for the most part. So you're going to have that CO2 still circulating around. As it goes through the tissues and CO2 is picked up from the tissues, you're going to notice that PCO2 is going to go up around 46 or so. And then you can see that it'll get dropped back off the lungs again. Okay, so all based on these pressure differentials. All right, so how do we regulate our breathing? So basically this contraction and relaxation of the breathing muscles gets controlled by these motor neurons in 2 areas of the brain. So we have some that's going to be revolving around voluntary breathing from the cerebral cortex. So I can say, hey, breathe in, breathe out. Okay, that's fine. But also a lot of it's going to be related back to involuntary breathing, usually from the respiratory control centers of the medulla and also the pons. This is the big spot where we see things like opioids affecting involuntary respiration to actually blunt some of these responses we'll look at. And this is where a lot of the apnea comes from and people dying because of that. It's a big deal when you end up having the brainstem being affected by this. You're going to notice that the brainstem is going to be responding to several different things. So things like having decreased O2 concentrations. Notice, you guys remember what this is called? This is the aorta here, the carotid sinus. Yeah, so the carotid sinus is going to have some of those chemoreceptors that can detect changes in O2 and CO2 and things like that. So having things like decreased O2 concentrations, increased CO2, increased hydrogen ions, all of that will have a positive effect on stimulating the respiratory drive, right? You're going to notice things like receptors in the muscles and the joints, noticing you're building up CO2 and hydrogen ions here, also going to all lead to increased breathing, because you notice that, hey, we need more tissue oxygenation here. And also having things like irritants, stretch receptors in the lungs that can have negative feedback on that there. So again, when you have normal inspiration, that stretch in the lungs will say, hey, we're done breathing here, and then you can expire back out again. Okay. Make sense so far? Okay, so again, these motor neurons are going to be innervating the diaphragm. They're going to form the phrenic nerve, and that actually arises from that cervical region of the spinal cord. So it's like C3 through 5 is going to help to innervate the diaphragm there. So this is why you have issues where patients have any kind of like spinal cord injury or that gets damaged. They can end up having diaphragmatic paralysis, and now they can't breathe on their own. So they end up having to be on a ventilator permanently. You'll find that those motor neurons that innervate some of the other breathing muscles end up coming from the thoracolumbar region of the spinal cord, and those are going to help with that kind of more accessory muscles rather than just the diaphragm, which is good for kind of quiet breathing. And then in the pons, this helps to influence the medulla activity. You're going to notice there's a few different centers here where you can see the apneustic center is going to be promoting inspiration, and the pneumotaxic center, which is going to inhibit inspiration based on some of these kind of motor feedbacks from things like the lungs, and etc. And then brainstem respiratory center help control breathing, mainly that phrenic nerve from C3 through C5. It's kind of the main places they're going to get controlled from. So again, just another picture kind of showing the different respiratory centers here, how they can be affecting both inspiration and expiration, have the different effects there. Okay, so going back to the chemoreceptors, we mentioned that these are important for this kind of automatic control of the breathing that gets influenced by feedback from these chemoreceptors. So things like monitoring the pH of the blood. If you have too high of a CO2 concentration, too much hydrogen ions, that stimulates you to breathe more or less. You breathe more, right, because you want to expire that CO2. And typically what you actually find is that the blood or the brain is going to be responding much easier to CO2 levels than it actually does O2 levels, right? So for instance, I knew these ER physicians that used to like to play a game on boring overnight shifts, and it was called DSAT. Okay, so basically what they would do is they would put a pulse oximeter on their finger. They would tell them the concentration of oxyhemoglobin, right, as you see on a monitor. And most of you guys, what should that usually be? What percentage? Yeah, it should be like close to 100, right? It should be 98 to 100, somewhere around there. For most of you guys, should be oxygenating appropriately. So they would go ahead and they would put the pulse ox on their finger, and they would sit there and hold their breath and see how far they get their saturations to go down. Whoever can get down the lowest would win. But what it illustrates is a very good point, because no one could really get it far below 98% because of the fact that you have so much oxygen kind of built up in the blood that can act as a reserve. Your brain is going to be responding to that CO2 far stronger than you will for that O2. So they're responding to, and why they needed to breathe all of a sudden was to get rid of that CO2. Okay, so it's just kind of an important kind of physiologic point. That's one of the things you're responding to. When you're looking at drugs like opioids, like morphine, that affect your breathing center, oftentimes what they're doing is actually blunting the brain's response to CO2. So even though you may not be breathing quite as much, you're blunting that response. CO2 is building up, but you're not able to respond to it and breathe more. So that's when they can eventually end up getting apneic and dying from that. So again, you see how the brainstem is very, very important for regulating this. A lot of it goes back to these this monitoring these chemoreceptors here, looking at things like pH, looking at things like CO2 concentrations, etc. Again, you have some peripheral chemoreceptors. They're going to be looking in the carotid body, as we mentioned previously, and also in the aortic body as well. So the aortic body is going to be sending feedback through the vagus nerve, right? So it's going to go through cranial nerve 10 there. The carotid body, though, is going to go through that glossopharyngeal nerve or cranial nerve 9. A little bit of differentiation there, how it gets signaled up to the brain. So again, when you end up having, looking at the regulation of breathing by the CNS, you have the cerebral cortex. That can lead to voluntary breathing, as we know. And then otherwise, you're going to end up having the brainstem kind of controlling things through these two centers. All information gets carried over to the medulla, where you can find that the chemoreceptors and the aortic carotid bodies are going to be kind of signaling over the pons, hey, how should we be breathing here? And that's all going to affect those motor neurons in the spinal cord to allow you to breathe kind of automatically and change your breathing as you need to in order to make sure CO2 levels, O2 levels stay right where they should be. So looking at the effects of pH and CO2 on the ventilation, I mentioned in hypoventilation, CO2 levels end up rising. So if I'm not breathing enough, I'm not exchanging enough CO2, they call it hypercapnia, and pH should fall at that point. Okay. In hyperventilation, though, I'm breathing off too much CO2, because again, I'm exceeding that metabolic rate, the alveoli, the air that's there. So I'm breathing off a lot of CO2. That's called hypocapnia. And then you're going to see the pH will end up actually rising at that point. You get more alkalotic in those cases. So Interesting if you guys are in some hospitals nowadays. Normally we would just measure pulse oximetry on the finger in a lot of cases. A lot of times that doesn't really tell you the full story, and so what nowadays we're doing is actually measuring end-tidal CO2 for a lot of patients. And basically we just put like it looks like a nasal cannula, you put it right there in the nose, and actually measures the amount of CO2 that's coming out of their expired air. And so we want to make sure that's maintained within a certain limit, otherwise it shows that they could be retaining too much. So if they're not breathing and they're hypoventilating, they can get hypercapnic, and that will be measured. Or if they're breathing too much and they're blowing down their PCO2, that could be another sign. Okay. Actually, it was interesting. We had a case the other day where we had a 6-week-old baby who we actually had to do CPR on. And so one of the things that the paramedic was doing CPR, he was looking at the PCO2, measuring off of that, and he knows that if he's pumping and getting good circulation on that baby's heart, he should be generating some PCO2. If he's pumping too fast, you end up seeing the basically they're not getting enough tissue oxygenation. You see the PCO2 end up dropping some, or if he's not being fast enough, that CO2 is going to start to increase. And so he knew he could change how fast he was actually beating that baby's heart based on the PCO2 that's actually coming out and that metabolic exchange that was happening there. So again, sometimes these things will come up in clinical practice every once in a while. But ventilation is maintained to control your pH at around 7.35 to 7.45. Outside of that range, things start to get a little wonky. We like to be able to breathe and make sure we get back to this kind of standard range here. I mentioned that increased CO2 is that primary drive for breathing. You're going to respond much more easily to CO2 than you will to drops in O2. Okay? And just notice how by CO2 levels rising, O2, pH dropping, that's all going to lead to the medulla and the pods being stimulated. This is where you're going to start to either get the diaphragm working harder, or you start to get some of those accessory muscles involved as well to try to get that breathing to occur. So a lot of times patients are not making themselves breathe with all those accessory muscles. It's the brain stem that's controlling that. Okay, so just looking at the effects of PCO2 on ventilation, again, you have the total minute volume as liters per minute here. I think my thing got a little goofed up. We have arterial CO2, so again, hypoventilation should be seeing PCO2 start to rise and increase. I said normally you should be expecting PCO2 to be like in the 40 to 45-ish range in the venous blood. During normal ventilation, you should be able to keep it right in that range pretty well. If you have hyperventilation, you're going to see that it starts to drive down lower, and then this is when you get more alkalotic as you're breathing off too much of that CO2. Okay. So again, and all this is just negative feedback loop. So if your brain is sensing, hey, we don't have too much CO2, it's going to stimulate to breathe faster. That'll end up increasing the pH, get back to your normal range, and your brain says, okay, we are breathing fast enough. Let's go ahead and slow it back down to standard. So it's pretty simple negative feedback loop you're going to see with that. And again, all those muscles are going to get involved as needed to make sure we're keeping the pH within range. Okay. So looking at the effect of blood PO2 on the ventilation, so O2 levels are going to be indirectly affecting that ventilation, as we kind of mentioned, by affecting chemoreceptor sensitivity to CO2. So O2 can kind of have a helpful role here, making it so that low blood O2 levels are going to make the carotid bodies more sensitive to CO2. And so why would that be helpful? So I have low O2 levels, carotid bodies become more sensitive. They are detecting that CO2 to a greater degree. That's going to help stimulate breathing. So that not only deals with the CO2 problem, also deals with the O2 problem as well. Right? So we can deal with kind of two birds with one stone at that point. And so we call this a hypoxic drive, where the carotid bodies are going to respond directly to low oxygen dissolved in the plasma, usually when we get below 70 millimeters of mercury. Again, this is on the arterial side that we're going to be measuring this. So again, normally we said that coming out of the lungs should be around 100. Was our partial pressure of oxygen there. So once it gets down below 70, maybe only 30% drop there, that's when we're going to start to say, hey, we're hypoxic here, we need to start breathing more and help to stimulate that. Okay. So again, just looking at the sensitivity here, so the increased PCO2 should be affecting those kind of medullary chemoreceptors in the aortic and carotid bodies. And again, we know that's going to help to stimulate breathing to get rid of that CO2. Also going to find you have some chemoreceptors that are going to be sensitive to pH in the CSF as well, so that can be affected in certain disease states there additionally. Lower pH be detected within the aortic and carotid bodies. This is going to be helping to stimulate breathing as well to help breathe off that CO2 to bring the pH back up. And then finally, the PO2 mainly going to be detected in that carotid bodies. That's where you have that hypoxic drive that gets triggered as you have hypoxia develop, usually less than 70 or so millimeters of mercury. Okay, everyone with me so far? You know what's stimulating you to breathe, what's inhibiting you from breathing, you know how the gas exchange is occurring within the lungs there. Let's talk about hemoglobin and oxygen transport. So hemoglobin itself, we know, is where most of the oxygen in the blood is actually going to be bound to. A small amount of O2 is going to be saturated or be dissolved within the plasma itself, but the majority of it is going to be linked up with this hemoglobin here. Each molecule is going to carry 4 molecules of O2, and then you have millions of them in any given red blood cell. So you can carry quite a bit of oxygen at any given time. So each red blood cell will carry millions of O2 molecules. Quite efficient carrying there. So here's an example of a pulse ox here. You notice how it says like an SpO2. It's kind of telling you the percentage of oxygen you have dissolved there, and measuring around 97%. You can see people up to 100%, especially if you're giving them exogenous oxygen. As you start to get down in the 80s, you start to worry about patients. 70s for sure is not a good sign. But basically, this measures the amount of total oxyhemoglobin to the amount of total hemoglobin there in the bloodstream. Okay. Do you know how it can tell the difference between these two? She does it based on light absorbance. So if you ever notice those pulse oxes, they actually shine a red light, and they're able to tell based on the absorbance of light between oxy and deoxyhemoglobin. It can measure the difference there. So again, just measuring the percentage of the hemoglobin carrying oxygen at any given time, usually in the high 90s is where we like to keep it. You can also do it with a blood gas machine as well, when doing like an ABG or something like that, but usually pulse ox is the easiest non-invasive way to do that. All right. So your hemoglobin concentration, we mentioned, what's a stimulus to help increase red blood cell production, hemoglobin production? It's a hormone that can do that. Yeah, erythropoietin's a big one that's produced where? Kidneys, absolutely. So looking at the oxygen carrying capacity in the blood, it's going to be measured by that hemoglobin concentration. If we have anemia, that's going to mean we have below normal hemoglobin levels. Polycythemia is just going to be above normal. You can see this a lot with like blood doping, or if you had someone with a high altitude, their body's trying to respond to that by increasing the number of red blood cells and thus the number of hemoglobin molecules available. So again, above normal levels. I mentioned when you have things like low O2 levels or things like that, we're detecting we don't have enough hemoglobin to carry oxygen around. This is when we have EPO being produced in the kidneys to help stimulate red blood cell formation in the marrow. And so you can see here kind of the differences with the concentrations. Notice what do you call this percentage here of red blood cells out of the total volume? Yeah, it's a hematocrit, right, versus just the hemoglobin concentration itself. Okay, so looking at loading and unloading of oxygen from the hemoglobin. So loading is going to be when oxygen is going to bind to the hemoglobin molecules within the lungs, and then we have unloading that occurs when oxyhemoglobin drops off the oxygen at the tissues. Okay, so we're going to see some of the factors that influence the unloading and loading of this process here. So looking at tissue unloading, this is going to be when we're dropping off oxygen at the tissue site. And we're going to be looking at the oxyhemoglobin dissociation curve. You can see this curve right here, essentially. Notice here on the y-axis, you're going to have a percent of oxygen saturation of hemoglobin, right? So again, 100% saturation can occur here. And you're going to have the partial pressure of oxygen. All right. So looking at the systemic arteries, they're going to start out, when they come out of the lungs, the PO2 of around 100 millimeters of mercury of oxygen, right? It's a partial pressure there. And so this is going to make it so you get roughly 97% of that oxyhemoglobin being held, okay? 3% of it may not have any oxygen bound to it, but 97% roughly is going to be bound there. Systemic veins have roughly a PO2 of around 40 millimeters of mercury. We said that when this gets back to the lungs, they've roughly got about 75% oxyhemoglobin. You probably lost 1 molecule on average of oxygen off all those hemoglobin molecules. And so you can kind of see how this kind of shows up on the curve here, where you have a PO2 of 100, roughly 97% being bound. Down here, PO2 of 40, you have roughly 75%. So what do you think is the difference here? Like, why would oxygen be more likely to dissociate from hemoglobin at one site versus the other? Yeah, it's kind of concentration. So for instance, if I'm delivering oxygen to the tissues where there's a relatively low amount of oxygen, right, because I've used it all up to make things like ATP, now I have a lower pressure differential there, lower PO2 in the tissue. The oxygen is going to dissociate and donate itself over to the tissue, okay? And then when it gets back over to the lung, they have a much higher pressure differential there. It's going to be able to pick up that new oxygen. And we're going to see there's some other things that are going to change and can shift this curve one direction or the other to make it so you're more likely or less likely to actually bind up and drop off hemoglobin at that point. So again, roughly with one circulation through the bloodstream, you're going to see about 22% of oxygen gets unloaded in the tissues, which is why you can hold your breath for several minutes and not die, because you still have a lot of oxygen left dissolved in the blood, right, on the hemoglobin. So we call this kind of shifting in the oxyhemoglobin desaturation curve. Basically what you can see is that you can change the pH, and that will affect how well oxygen binds to that hemoglobin. So for instance, pH you can lower the pH, make it more acidotic, and it causes the affinity for O2 to decrease. That means it's going to shift this curve over to the right. So lower pH shifts the curve over to the right, which means that oxygen is more likely to donate. It's more likely to unload off the hemoglobin, donate that oxygen to the tissues. And so in the tissues, when we're having oxidative phosphorylation, all this stuff, what do you think the pH is doing in those tissues as they run out of oxygen? They're producing more CO2. They should. Yeah, it should be relatively more acidotic. So the tissues should be more relatively acidotic. They've made a bunch of CO2 from generating ATP. So that's going to cause the oxygen on the hemoglobin to be more likely to donate itself to the tissues. Okay. On the flip side of that, if you go over to a more alkalotic pH, say like 7.6, this causes the curve to shift over to the left. This means that oxygen is going to be more likely to bind to the hemoglobin and stay bound there. And so where do you think the pH might be higher in the circulation? Like where you might be expelling a lot of CO2? In the lungs, absolutely. So as you increase the pH in the lungs is going to be relatively a little bit higher, and that's going to cause the oxygen that's coming in through the alveoli to be more likely to bind that hemoglobin and stay there. Okay, so you're going to notice there's going to always be this shifting that occurs where the hemoglobin goes out to the tissues, relatively a little bit more acidotic, more likely to drop off oxygen, versus when it goes into the lungs, it's going to be a little bit more alkalotic. It can pick up oxygen and hold on to it more tightly. Okay, so it's called the Bohr effect. It's not what happens when I talk to you for 4 hours straight, right? So make sure you guys are awake. Describes that effect of pH on that affinity for hemoglobin. So think about acidotic situations. You're going to cause a shift to the right. You're going to cause more likely for oxygen to be donated off a hemoglobin. If you're in a more alkalotic situation, medium, you're going to be causing the line to shift to the left, causing oxygen to bind more tightly to oxyhemoglobin. So you can kind of see this looking at the arterial O2 concentration based on different pHs here, how this shifting can occur. Just notice that you're in a more acidotic state, you're more likely to unload that tissue oxygen, right? Because that's where it's needed. And the more acidotic medium, so it can get rid of that CO2 as well. But we really want to drop off that oxygen there. Temperature is also going to have an effect here. So we mentioned that when you have production of ATP, we said we generate things like CO2 and water. What else does because we said it's not a totally efficient process. What's another byproduct that process? Yeah, heat, right? So temperature is going to have an effect on the oxyhemoglobin desaturation curve as well. So for instance, you're going to see that hemoglobin affinity is going to be decreased at increased temperatures. That's going to cause a shift to the right, which means that as I go from the lungs, which is relatively cooled, to the tissues, which is going to be a little bit hotter, you're more likely to donate oxygen off the hemoglobin, okay? Which is a good thing because we want to get rid of that. And then when it gets back up to the lungs, those colder temperatures, relatively speaking, is going to be able to cause that binding affinity to be higher and cause the oxygen to bind tighter to that hemoglobin, which is what we want because we want to pick up that hemoglobin, or that oxyhemoglobin, to take it to the tissues. Just know that high temperatures shift it to the right, low pH is shifted to the right, high pH is shifted to the left, low temperature shifted to the left. Okay. So again, just notice they're going to have a kind of opposite effect here as far as how they're going to change. So decreased pH, increased temperature cause a decreased affinity, causes the shift to occur to the right, which means you're more likely to donate oxygen to the tissues. Okay. All right, next we have carbon dioxide transport. We can look at real quick. So carbon dioxide transport, this is going to occur primarily, you're going to find we saw a small amount of it's going to be dissolved just in the bloodstream and plasma on its own. A large amount of it's going to be carried as bicarbonate, and then some of it will actually be associated with the hemoglobin itself due to some of those kind of weak forces. We call that carbaminohemoglobin, and that's the CO2 attached there to the amino acids within the hemoglobin itself. Okay. Again, you remember the enzyme that's responsible for converting carbon dioxide into bicarbonate? Carbonic anhydrase. Yeah, it's going to be a really important enzyme here that does that. So there's also an effect called this chloride shift. So once CO2 Again, because it's going to be in higher concentration in the tissue out here in the capillaries. As the blood flows by, you're going to have CO2 that wants to be picked up because it's in a relatively low concentration in the blood cells or in the plasma versus high concentration in the tissue. So you're going to have natural diffusion occur here. Once that carbonic anhydrase converts the CO2 back to bicarbonate, then that bicarbonate can then be shifted out of the red blood cell. It can't really cross by itself because, again, things that are charged, they don't like to cross those biologic membranes very easily. So what we do have is a co-transporter that will bring chloride in and put bicarb back out, and that way it keeps the charge essentially in the red blood cells the same. So you're bringing in a negative, sending out a negative. And so we call that a chloride shift that occurs there to increase those chloride concentrations within the red blood cell. Because why do we want the bicarbonate outside of the blood cell? So that we can act as a buffer, right? It can get associated with hydrogen ions. It can neutralize the system if it needs to, or dissociate if it, depending on the pH. So it's really important that we have the bicarbonate available in the plasma to be able to act as that buffer. Okay, so you can look at that Bohr effect, bonding of hydrogen ions to hemoglobin. That's going to lower the affinity for O2. Again, it helps with that unloading. So again, lower pHs helps to shift that curve over to the right, drops off oxygen over the tissues. The hydrogen ions also going to help the blood carry more carbon dioxide and more CO2. So again, in acidotic situations like the tissues, they're now generating excess acids and things like that. It can be more likely to be picked up by the hemoglobin and be transported over to the lungs where they can be expired there. And then again, describes the effect. Basically just that pH for the affinity of hemoglobin to oxygen, but CO2 is still going to play an important role here depending on the hydrogen ion concentrations. Okay. When you get up to the pulmonary capillaries, we're going to have the reversed effect happen here, where you're going to want to get rid of the CO2 that you've had there. So again, increased PO2 favors the production of oxyhemoglobin, as we mentioned before. Basically, this is going to make the hydrogen ions dissociate from the hemoglobin. It's going to recombine with that bicarbonate, and then carbonic anhydrase is going to convert it back over into CO2. Okay. Once it's into the CO2, then the chloride can then diffuse out as the bicarbonate enters, and then you can get rid of the CO2 eventually. Okay. Everyone still with me? So again, at the alveolar side, this is where the carbonic anhydrase lives here. It's going to convert that carbonic acid back into CO2 and water, and then the CO2 can then be expelled. So again, it's in a lower concentration in the alveoli versus in the blood, so it's going to be able to transfer that out pretty easily through diffusion and get rid of it. So you can just notice here, so I think I misspoke on that previous slide, but basically when you have this conversion, you're going to convert the bicarb. It's going to get back into the cell. It's going to get back out of the cell. It's going to have that reverse chloride shift there. The carbonic anhydrase is then going to shift the carbonic acid into CO2 and water. You can just expel that to the alveoli. Okay. So I think I'm going to go ahead and cut it there. How many slides do I have left? You guys know? A lot? Okay. I'm going to go ahead and cut it here. I will record the rest of this, and then we'll do a review tomorrow. I'll try to get this put up as soon as I can. I'll put out an announcement when I do. Any questions? That was a whirlwind tour. Left you breathless, huh? Okay, I'll talk to you guys in a bit.